So I'm going to talk about the evidence, and I'm going to use the recent guidelines from the ESC and ERS, recent guideline that was released only a few months ago, to look about the evidence for combining treatment in pulmonary arterial hypertension. Now, to start with, going with the first talk about the different groups, and the first message I would like to address here is that these 5 groups are really, really different. They're not similar at all. And this is why when you look at treatment approach, at the moment, we're saying that those kind of target therapy we used only in group 1 disease and maybe in group 4 disease. So that should be very clear to start with. However, in 1 prime, the veno-occlusive disease, we can still use these drugs, but with a lot of cautions. These drugs so far are not indicated in group 2 and group 3, and they could be as well harmful. And in group 5, they are not even indicated because there is no data. So we need to keep that in context when we look about treatment for pulmonary arterial hypertension. So again, I'm emphasizing that the talk today will be to great extent on group 1 pulmonary arterial hypertension group. And as we heard from previous speakers that we have targeted therapy, and when we start combining treatment, we would like to have a goal. What are we trying to achieve when we decide to combine treatment? And the guideline tell us that we would like to have our patient in what we call the green zone, or the low mortality zone. And that, as we're going to hear later on this conference, that you're going to look for a combination of clinical symptoms, function classes, exercise, ecoparameter, and hemodynamics. And when those are all on the acceptable range, that indicate probably low mortality for the patient, and those are the target of our treatment. We have those at intermediate risk, so they have some of those targets been achieved and some of them were not, and we call that those are intermediate risk group, and they have an annual mortality of 5 to 10%, and definitely you don't want your patient to be in the risk zone where the mortality is extremely high, more than 10% annual mortality. But the guidelines are very clear that when you look at it, we are targeted, or our goals is to go for the green zone, and that's what is allowed to be acceptable outcome for our patient. And again, they emphasize that the red zone or the intermediate zone is not good enough. So, because the mortality is unacceptably high. When you look at the data in the randomized control trial that we're taking care in pulmonary arterial hypertension over the last few decades, we have up to 39 studies. This was until 2013, so still we'll have a few more studies later on. And then when you look at this data, some of these studies, which are now in the black color, they were looking at monotherapy versus placebo. Those were the earlier studies that looking at monotherapy treatment versus no treatment. And those were followed by what we call of adding on treatment, what now we call sequential combination treatment. And we have only 2 studies that were in a way looking at upfront combination, so to really start at testing the theory of having upfront combination from the beginning. Now, looking at the basically treatment algorithm, I would like to emphasize on one thing here, that the algorithm start talking about combining at the level of the general measure, because sometimes we don't use this measure as a mode of therapy. We always, when we talk about monotherapy, we talk about things like sildenafil or bosentan. But as a matter of fact, looking at the general treatment is really a part of the combination therapy. You would like to have specific recommendation for the patient that, for example, avoid pregnancy, immunization, etc. And these are really part of the treatment strategy. It is a way of thought, if you like, towards combination treatment. Similarly, supportive care. It is part of the combination treatment. Diuretics, for example, is a very important treatment tool sometimes in really somebody who comes with severe fluid overload and dry-sided heart failure. And I don't imagine that any other drug will work if you don't combine that treatment with diuretics. Anticoagulation, for example, on CTEPH patient, this is kind of a must. And you cannot think about combination treatment without having this in mind. And finally, looking at the calcium channel blocker. And nowadays, we recall that those patients who do have specific characteristics, we call them vasoactive basically patient, they are candidates for a calcium channel blocker. But we learned that not all of those patients who are candidates for this treatment will continue on this drug basically as a monotherapy. Significant percentage of those patients will require another drug. So the calcium channel blocker can also be one group of the combination treatment. But let's go for now those who are non-vasoreactive, and we start thinking about monotherapy versus combination treatment. Keep that table in mind, that our target is to keep the patients in the green zone to ensure that the mortality of those patients are acceptably low. And here the guidelines gave us different approach. All of them are evidence-based, either about using initial monotherapy and then have an add-on sequentially, or to use oral combination treatment from the beginning, or use upfront combination, including IV prostacyclin. So you have these options available to you, and I'm going to show you the data that's supporting that approach. Now, when we look at the monotherapy evidence, you can see that most of the drugs that we are using at the moment, they have a class of recommendation 1, based on reasonably, well, I'll say most of them are based on good studies, based on randomized placebo-controlled studies. We have that for ambrisentan, bosentan, and macitentan when we go for patient function class 2 or 3, and we have that as well with the phosphodiesterase 5 inhibitors, sildenafil, tadalafil, and with riociguat arm. So most of the oral therapy that we use as a monotherapy, they have very solid data to support their efficacy, and the class of recommendation is quite high. Now, when we look at upfront combination treatment from the different strategy, from the different randomized controlled trial, we have one study that you're going to hear about the next speaker, which is the Ambition trial, talking about ambrisentan sildenafil, showing a very good outcome and decreasing the morbidity and mortality endpoints. Okay, that's something I should, okay, well, that's fine. And then you have other combinations that be tested, such as basically ERA, macitentan, and bosentan with phosphodiesterase 5 inhibitors, but they were not addressed. Well, actually, BREATHE 2 study addressing, in a way, combination treatment using bosentan with IV prostacyclin, but I think still it's in the Ambition trial, which is the best one. So it's the only one which has level B, because it is a randomized controlled trial, but it's only one study and a class of recommendation 1. But I would like to test this theory, because now with these two data, is it now justifiable to look at the goal-oriented treatment as the best or the standard of care? And let's look at the SERAPHIN study that was already mentioned before. In this paper, macitentan has shown to be quite effective at a dose of 10 milligram and 3 milligram, but the approved dose is the 10 milligram dose compared to placebo when it's added to other, basically to drugs, to the background treatment. So this was, in a way, a sequential treatment. But when you look at the patient characteristic, you can find out that about 50% of those patients were in function class 1 or 2. So basically, those patients, probably they were already on the green zone. They were not having any problem. They were stable clinically. And about 60% of the patients received combination treatment despite the fact that they were in the green zone. So that's not the goal-oriented treatment, because goal-oriented treatment that you need to be not in the green zone, then to add drugs. But here, in the Seraphim study, those patients were on stable green zone area, and then macitentan was added to the other drug, which was to a great extent phosphodiesterase 5 inhibitor or pusinate. And what they found that even in those patients who were in the green zone, combining treatment was effective. And as you can see in those who were in function class 1 or 2, there was 42% reduction in the endpoint, which is the morbidity and mortality. And that kind of tested or really challenged the goal-oriented approach, that we need to wait until there was some goals are not basically targeted before adding another drug. And this was kind of eye-opener. Maybe we should not wait to do that. Maybe you should go from the beginning to very powerful upfront combination treatment in most patients. And the finding, as I said, really challenging the concept of the goal-oriented treatment. Similar strategy was found in the patent study. We're using riociguat in patients in pulmonary arterial hypertension patient. And again, riociguat was effective, improved 6-minute walk distance significantly in those patients. But again, when you look at treatment naive or those who were in upfront combination, who were on background treatment, riociguat was effective. And again, indicating that maybe even patients in the green zone might benefit from early combination treatment. And that's probably took us to a new era of what we call outcome-oriented treatment, not goal-oriented treatment. You don't need to wait for clinical worsening or goal worsening. Maybe we should start very aggressive really from the beginning. And I'm sure we're going to hear more details about the AMBITION trial, but the AMBITION trial really tested that strategy to great extent. But that was the main goal of the study. Those patients who suppose significant number of them, they were in function class 2. They were basically stable, and were randomized for combination treatment versus monotherapy. And what we got, that I'm going to hear about that later on, but the outcome was marvelous. About 60% reduction, 50% reduction in the outcome, and 60% reduction in hospitalization for patients, even in those patients who were stable clinically. So, as I said, the implication from the Seraphim, the patent, and the AMBITION trial, that probably now we should move further from monotherapy treatment, waiting for deterioration. We already moved to the goal-oriented treatment, that we don't need to clinical deterioration, but to goal unmet. And now probably we're going to start talking about outcome-oriented treatment. Even very stable patient, very milder disease, they probably should be treated by a combination treatment from the beginning. Now, when we go further and looking at about the treatment algorithm, again emphasizing that the guidelines is strongly recommended that the patient should all the time be in the very stable condition. And they talk about the green zone table. Now, if you look at from the other aspect, which used to be the standard of care, where you have sequential combination treatment, I think we have now good data from the Seraphim study that macitentan can add it to sildenafil, riociguat added to bosentan, as shown by the patent study, and those are based on very high class of recommendation. Selexipag, which is the new prostacyclin basically receptor agonist, in the Griffon study has shown as well to be very helpful as a sequential add-on treatment. And finally, that I would like to talk about is sometimes other measures can be combined, including IV treatment. Basically vasoactive treatment, ECMO treatment, sometimes mechanical ventilation in those patients who are extremely sick, although you would like always to try to avoid this. But all of these, and of course lung transplantation, atrial septostomy, I always look at these as a way of combining treatment. I think personally, at a personal level, that atrial septostomy probably should not be left to the very end of the treatment algorithm. Maybe it should be used very, very early. Well, it's not very early, but early enough before the patient went into very, very advanced stage. So we need always to think, what I'm trying to really say here, that combination treatment might not only be medication. It could be oxygen. It could be avoiding pregnancy. It could be definitely calcium channel blocker, different medication. But the message that we are getting at the moment, that the earlier we use this aggressive treatment approach, probably is the better. So my take-home message, ladies and gentlemen, that I think we need to look at the patient in a very specific way. Each patient probably is different. As we used to say in bronchial asthma, everybody is basically different. I think that's true in pulmonary arterial hypertension. And until recently, the only specific phenotype that used to influence our initial treatment was the vasoreactivity, to go for vasodilator versus basically the target treatment. And I think nowadays we start realizing that, yes, that's important, but there's other aspects that we need to address as well. It's always important that now our goals of treatments are different. It's a composite endpoint of the clinical condition of the patients, biomarkers, echoparameter, exercise, and hemodynamics. We know that until time, it is the sequential goal-oriented treatment is probably the standard of care, and that means always keep the patient in the green zone. Whenever there is any deterioration, add other drugs to keep them back into the green zone. But I think nowadays that initial combination treatment with this different strategy of really outcome-oriented strategy might be the best treatment approach. Thank you very much for your attention.
I will speak about the ENVISION trial as was indicated before, but not just the clinical trial data, but I also want to explore a little bit why these outcome parameters that make us define things as a green zone or an intermediate zone, why these parameters may not be as good as we hope they are to really assess how the patient is doing. And most specifically, these parameters may not always be as good as we wish they are when we want to assess how the right heart of a patient is responding to the increased pulmonary vascular resistance. Because this is really what matters, how the heart responds in this disease. So this is a slide showing the data from a patient cohort in Amsterdam, published several years ago now. And these patients were basically treated with a goal-oriented therapy. It's a retrospective study, so it was not as clearly defined as in the randomized clinical trials, of course. But as you can see, with initial monotherapy and then added on to this monotherapy, if the patient was not doing that well, a combination of treatments, you can see that by far the majority of patients show a reduction in pulmonary vascular resistance. So this plot shows changes in pulmonary vascular resistance and changes in on the x-axis, and changes in right ventricular ejection fraction measured by MRI after 1 year of treatment. So some of these patients were monotherapy and some of these patients were escalated after their first reassessment after 4 months of start of therapy. But as you can see on this left-hand side, about 2/3 of patients respond with a decrease in pulmonary vascular resistance. So you would say that is quite favorable. Most patients are responding. But as you can see also, the response of the right ventricle to this decrease in pulmonary vascular resistance is not really tracking this change in pulmonary vascular resistance. There's a huge scatter between the data, and really a reduction in pulmonary vascular resistance is not followed by an improvement in right ventricular ejection fraction in all the patients. And also what is also evident from this slide is because the blue dots show the patients who are surviving after this 1 year initial period, what you can see is that all the patients that do not show an improvement in right ventricular function, or even a decrease in right ventricular ejection fraction, those are the red triangles, and those are the patients who are most likely to subsequently die after this first year. And this is another way of plotting this. This is a summary of all the patients who did have a favorable response in pulmonary vascular resistance. And the big separation of these two groups is that the patients who went on to survive had an improvement in right ventricular ejection fractions, whereas the patient who deceased showed a decrease in this first year of follow-up. So how can this be explained? How can the resistance go down and still the right ventricle fare worse? Well, this kind of complicated slide is an attempt to look at the data from randomized clinical trials in a little more detail. As you can see here is a graph plotting the change in stroke volume after treatment against the change in pulmonary artery pressure. These two parameters are important because the product of the two is the power output of the right ventricle. So that's really the work that the right ventricle needs to do in the patient. So the green arrows show all the patients on active treatment, and blue arrows show placebo treatment. And as you can see, in most patients there is an increase in stroke volume index. In virtually all the trials, you can see there's an improvement in stroke vascular index. But the decrease in pulmonary artery pressure is usually not that large. It's usually quite modest. So there is a big decrease with prostacyclin treatment. You can really see a decrease in pulmonary artery pressure. But with most other treatments, the reduction in pressure is quite modest. So when you calculate the product of the two, the stroke volume index, the change in stroke volume index multiplied by the change in pulmonary artery pressure, you can see that the work of the right ventricle is actually increasing with treatment. So the right ventricle is not being alleviated of its task, but it's actually working harder, which may not be that favorable. So what most of these treatments do, and this kind of clinical course of a patient was shown on a previous slide. So what we usually think about our patients is that when they become clinically apparent, when they start to have symptoms, their pulmonary artery pressure is already pretty high, and it increases still a little bit more. And in very advanced disease, it may even decrease a little bit. And the stroke volume is initially maintained quite well, but over the course of disease progression, when the patient goes from functional class 1 to 2 and 3 and 4, there's a gradual decrease in stroke volume. And as shown in the previous plot, what most trials do is patients are being treated relatively late. There is little, if any, change in pulmonary artery pressure, and there is an improvement or an increase in stroke volume. And as such, the power output of the right heart is being increased. So this, of course, is not necessarily bad. If the heart is doing better and can increase its stroke volume, why not? It's probably because the heart is functioning better. Well, that's not necessarily true, because the right ventricle has basically two options to increase its stroke volume. It can either increase its intrinsic contractility, or it can increase its volume, the Frank-Starling mechanism. And as you can see from several studies, they're relatively old, but at least these studies had measurements of right ventricular volumes to see what the changes in right ventricular volumes were when patients were put on mono treatment. And as you can see in most of these trials, a lot of the increase in stroke volume index is not coming from an increase in contractility, but it's coming from an increase in volume. So the right ventricle enlarges, which may not be such a good idea, because a bigger right ventricular volume or a bigger radius means an increase in wall stress. And wall stress is, at least in the left heart, recognized as a very important predictor of a poor outcome of a ventricle. If the wall stress is increased, it means that the perfusion of the right ventricle is becoming worse. The cardiomyocytes may become overstretched. So this is really not a good idea. So this may really be a problem with all the monotherapies, that even if we do get an increase in stroke volume, a lot of it is coming from an increase in the right ventricular volume. And this is not a good adaptation mechanism. So to summarize it again, a lot of monotherapies in pulmonary arterial hypertension are associated with a decrease in right ventricular load, a decrease in pulmonary vascular resistance, an increased stroke volume and exercise capacity, but there is no reduction in right ventricular power output, and there is no reduction or even increase in right ventricular wall tension. And this may lead to worsening of RV failure. So what can we do? Of course, it was already alluded to in the first talk. We can try to treat really early. We can try to find out which patients are having almost asymptomatic or very mild symptoms, and we can try to treat them at the stage where we can really still effectively reduce pulmonary artery pressure and maintain stroke volume at the same level, and as such decrease power output of the right ventricle. This is a very difficult issue, and it will be talked about later. Perhaps we can use exercise, but a lot of questions still have to be resolved in terms of what kind of exercise protocol and what kinds of normal values do we have. Does it really help early treatment? So a lot of questions still need to be answered. So the other option is aggressive treatment, and for a lot of in Amsterdam, for example, pulmonary hypertension is treated in the pulmonary division, and we have two focus areas. One is pulmonary hypertension, and the other is oncology. And this is really a no-brainer for oncologists. Of course, you're not going to give one treatment to a patient. Well, how could you think about this? You just hit the patient as hard as you can with all you have, and you hope you can get a good improvement. So that's basically a good rationale, because we also know from, for example, lung transplantation or endarterectomies for chronic thromboembolic pulmonary hypertension, that if you are really able to get a massive decrease in pulmonary vascular resistance, so you decrease pulmonary vascular resistance by 60 or 70%, this will really predict an improvement in right heart function. Only in these cases you can really see an improvement in right ventricular ejection fraction. So initial combination treatment or sequential treatment, a lot of it also hangs together, of course, with do we have good parameters to follow our patients? Well, I talked about the volumes. It seems, in our experience, it seems quite ideal to use as a goal of therapy a decrease in right ventricular volume. But this is not so easy, because echocardiography is not always that reliable if you want to measure right ventricular volumes. And MRI is perhaps ideal, but not so readily available around the globe. So could you use those surrogates, exercise capacity, either a 6-minute walk or a peak oxygen consumption or a BNP, or any of these variables to achieve the same thing, and just do a very early follow-up on your patient, and only if you do not reach your goals can you up-titrate and get the same benefit of a reduction in right ventricular ejection or of an increase in right ventricular ejection fraction. Well, this approach is a little bit problematic, because although the guidelines use all these prognostic parameters in their definitions of green zones and intermediate zones, the elephant in the room actually is that a lot of these parameters may predict survival at baseline, but they may not be as good during follow-up. So a parameter that increases survival when you see the patient for the first time, like 6-minute walk distance or pulmonary vascular resistance, they are quite predictive if you see the patient for the first time. But it doesn't mean that these parameters are still predictive of subsequent survival if you do a follow-up measurement. And actually very little is known about these parameters, and little is known about really good, reliable parameters for follow-up. So that is definitely a problem. So you can question whether we are really sensitive enough with our usual clinical parameters to predict longer-term worsening and to predict longer-term dilatation of the right ventricle. Well, if you're not convinced yet that right ventricular volumes are really important in predicting how a patient will do in the long run, this is also a study from Amsterdam showing the data on a small group of patients, but a group that is becoming larger and larger. And those are the patients that survive for quite some time, 3 years, 4 years, 5 years. We have a lot of patients in our center. But still we know that all of a sudden they may deteriorate. And this is becoming a more and more common problem, because of course our therapies are quite effective, but still at a certain point patients may deteriorate, and we don't really know when this is going to happen. So these patients were by definition patients who survived at least 5 years. There are 20 patients, and out of these 20 patients, 10 went on after the 5 years to deteriorate, and 10 went on to remain stable, and they in fact they still are stable and alive. And these patients all had, at the 5-year stage, very similar 6-minute walk distances, functional class, all the usual parameters were quite similar in these patients. But as you can see, the measurements by MRI, the volumetric measurements, were really very different. So those patients who went on to progress in a late stage of their disease after 5 years, these patients actually already very early on showed this maladaptive right ventricular response of a dilatation, either whether you measure it with end-diastolic volume or end-systolic volume or right ventricular ejection fraction. It was really the dilatation which made the difference. So now going to the AMBITION trial. I try to make the argument that it's difficult to use a goal-oriented therapy, and there's a lot of rationale to hit early and hit hard, and this trial is basically really all we have to really prove that this concept could work. The trial has been talked about quite a bit already over the course of today. I'll provide a little more detail perhaps. So this was a trial where patients were randomized 2 to 1 to 1. 2 was the patients on combination therapy, and they were randomized against monotherapy with either tadalafil or ambrisentan. And as was said previously also, this was an event-driven study. The study ended when a certain number of predefined events occurred, but also at 6 months there was an evaluation time when a lot of secondary endpoints were being assessed and compared between the treatment arms. So the endpoint was a composite endpoint, and this is of course very interesting from a standpoint of trial design. It was a composite of death of all cause, hospitalization, or these two relatively newer endpoints, an endpoint of disease progression, which was defined as a decrease in 6-minute walk distance from baseline by at least 15% in combination with still being in a functional class 3 or 4, or this unsatisfactory long-term clinical response, which was defined as a decrease in 6-minute walk from baseline. And again, patients already on treatment for at least 6 months, together with still being in functional class 3 or that is it. So either a decrease in 6-minute walk distance or functional class 3 after 6 months of treatment. This has also been alluded to. This is a little bit complicated in this study because at first patients were enrolled under relatively mild criteria, and it appeared during the first analysis of the patients that were enrolled that the population was kind of different from those populations of earlier trials. There were a lot of patients with diabetes, a lot of obese patients, so the kinds of patients we are seeing more and more in the Western world, which seem to have maybe not hemodynamically a group 2 phenotype, but still they have a lot of risk factors of being occult left heart disease. And the fear was that these patients were actually not good for the trial because they may not respond to treatment. So there was an amendment made to the protocol with more stringent criteria to enrich the population with real old-fashioned, as you might call it, pulmonary arterial hypertension. And the analysis ultimately was done on the patients who fulfilled the criteria of the amendment. So the more stringent criteria for group 1 pulmonary arterial hypertension. As was said previously also in the question and answer session of the first part of today, when the analysis was done with the whole cohort, so also with the patients who were enrolled before the amendment, the results were still the same. So that is a very interesting finding of this study, that even those patients that resemble those group 2 pulmonary hypertension patients, even in those patients there may be an effect of the approach. So initially in these patients there were some more discontinuations of treatment in the first weeks on the patients on combination therapy, but when evaluated at 6 months, in total there was no difference in numbers of patients being withdrawn or lost to follow up in the patients. So the groups were well matched and the comparison was well matched. So in this primary analysis set, the patients look very much like previous trials, maybe a little bit older, 54 years of age, predominantly females, and as you can see, they were enrolled in different countries, in different regions, but the numbers for patients from Asia-Pacific regions was very small, so it's very difficult to draw any conclusions when it comes to differences between different populations in different regions. So most patients were idiopathic patients, 50%. A lot of patients also with connective tissue disease, and then some smaller subgroups. And of course, the patients were not allowed to have background therapy. Maybe there were some patients that received already bosentan for example, ulcers in their fingers for scleroderma. But basically, all the patients were really treatment naive when it comes to pH-specific treatment. Interestingly, it was a combination of functional class 2 and 3 patients, so we'll come back to that as well, because this is, for me, one of the most interesting parts of the study, that you can actually also say something about functional class 2 patients, whether this combination approach is of use. And the hemodynamics, I'll just leave them as they are for now. So the pooled analysis, the primary endpoint was a comparison between combination therapy against patients on monotherapy. So these two monotherapies were pooled together. The study was powered for this analysis. So tadalafil and ambrisentan monotherapy are here together represented as one group. And as you can see, there's a quite large risk reduction when it comes to the primary endpoint of combination therapy. Should I keep that? Take it off? Yeah? Should I start over again, or?
Keep it.
Okay. All right. So there was a 50% risk reduction with combination therapy in comparison to the pooled monotherapy. And as you can see here, this is a breakdown of the primary endpoint. This effect was a combination of an effect on death, hospitalization, or these two newer definitions of disease progression and unsatisfactory response. But basically, the significance really came from the difference in hospitalization. So that was really the main difference between combination therapy and pooled monotherapy. There were a lot less hospitalizations for pulmonary arterial hypertension in the combination therapy group than in the pooled monotherapy group. So despite the fact that we have these fancy new endpoints, the ultimate result of this study really didn't rely on these newer endpoints, although it did help, of course. So if you look at the separate therapies, there was also a possibility to do an analysis of combination therapy with either ambrisentan or tadalafil. And as you can see, the groups are very comparable, about a 50% risk reduction for both kinds of monotherapy with the combination of ambrisentan and tadalafil. So I hope this is possible to read. This will be very difficult to read in the other locations, I'm sure. But what it basically says is that again, as I said before, that the significant difference in outcome was really driven by a difference in hospitalization. Although the other parameters were also there was a trend towards clinical significance for the comparison of combined therapy to pooled monotherapy, and it didn't really matter what kind of pulmonary arterial hypertension you had, either idiopathic or heritable versus associated, was all significant. And very interestingly, the biggest effect even seems to be in the group of functional class 2 patients. So that is very remarkable. Even a profound effect in functional class 2 patients questioning basically all our approaches of goal-oriented therapy to a great extent. Age didn't matter, baseline 6-minute walk distance didn't matter, and region, although it was difficult to assess, of course, didn't really matter. And there was a slight tendency of the effect not being significant in male patients, which is another very interesting topic, of course, not for today, but differences in treatment responses between males and females is something that we will hear a lot more about in the coming years, I think, in the pulmonary hypertension field. So is this good enough, this oral combination therapy? I will conclude with a small pilot study from Olivier Sebon from Paris on upfront triple combination therapy. So that is a very aggressive approach, of course. This was also a pilot study in a group of severe patients, functional class 3 or 4. And these patients were all treated with triple combination therapy. So they received basically all bosentan and sildenafil in combination with parental prostacyclins. And this is, of course, a very small study, not placebo-controlled, but still the data were interesting enough to publish them in the European Respiratory Journal, because the effects are so shocking in a way. Because in these 19 patients with very severe pulmonary arterial hypertension, the outcome was very good. Actually, all the patients are still alive today. And the study was conducted several years ago. So this is beyond a green zone of a mortality of 5% in 1 year. And also the hemodynamic and functional changes with this upfront combination therapy were very remarkable, with more than doubling of the cardiac index and a great reduction in pulmonary vascular resistance, an improvement in exercise capacity, and also now with this combination therapy, a real decrease in pulmonary artery pressure. So these data, of course, very interesting. And at this point, at this time, there's now a new trial being started with the Selexipac, the oral prostacyclin receptor agonist, which also follows the same kind of idea of upfront triple therapy, and it will be very interesting to see where this will go. Of course, this is a complicated study. We also talked about the difficulty of conducting trials with placebo or not, and finding the good endpoints. So this will be really a proof of concept study with using actually PVR, good old PVR, as an endpoint. But it will be very interesting to see what kind of results this will yield. So to conclude, the rationale of upfront combination therapy is really to not only to reduce the right ventricular load, but also to increase stroke volume due to a real relief of the right ventricle. So by a reduction, such a large reduction in the right ventricular load that actually the diameters of the right ventricle can also decrease, and right ventricular power output can also decrease. Whether this upfront combination therapy works because of this mechanism, because of reduction in right ventricular volumes, is actually something we're studying right now in Amsterdam, and it will be very interesting to see whether this is really the mechanism. And by this, I would like to thank you for your attention.